right. We are live or we are recording, we are digitizing, whatever you want to say. But this is Planetary Health First, Mars Next. Don't worry about the name. I'm not, hope you aren't either. But we have a super cool guest. He's almost AI himself, but he's real. This is Dr. Graham Walker. And what I love about this guy is he's doing the real thing. He's an ER doctor still by day, probably a secret agent by night and doing other stuff too. Who knows? But he's super interested in technology and all things AI. And I love your stuff that we see on LinkedIn where you show your post, your visual tutorials. It's just super amazing. So anyway, thank you for coming on today.
Yeah, Michael, thanks for having me. It's I've loved your stuff, and yeah, I just love to talk about this. And I have no shortage of opinions or ideas, or I just like to try to figure out how we can make healthcare better. Honestly, better through technology is the way I like to view things.
So, how would you describe yourself? Do you think you're a physician? Like, I don't want to say advocate, but like a physician techno sort of like what would you call yourself?
Yeah, it's a great question because people ask me what I do all the time. Yeah, I think kind of physician advocate and physician technophile, while still, like what we were talking about before we started recording, wanting to make sure that we don't lose the practice of medicine and the ability to deliver high quality care through technology. I see all the ways that technology can help us. But I also have seen through my years in healthcare the ways where technology, if it's not approached through a lens of a healthcare worker, be it a nurse, doctor, pharmacist, whatever, it can absolutely kind of go astray and be hurtful, be harmful even to patients or just to burn out as well for
what is your biggest fear with healthcare and technology if we don't get it right?
Yeah, that's a great question. Man, I have a bunch. I would say one of my biggest certainly is that physician advice or seeing a physician is a luxury, and that it is no longer a kind of a standard or an expectation, right? That that AI is kind of quasi managing patients without really making sure that a human is actually agreeing with stuff. I was talking with some friends recently that, I could imagine a patient is kind of chatting with their AI healthcare doctor bot for months, and for whatever reason, they are not aware, because the bot is all through text or whatever, they're not aware that they're having really quite significant symptoms that need to be more aggressively worked up, right? The fatigue is attributed to their lack of sleep, or their weight loss is attributed to being stressed, when they actually have like a malignancy or something, right? Something devastatingly terrible like that. And then it's missed because like a doctor, a human, did not lay eyes on them. Now, I mean, the American healthcare system is far from perfect, and I know those stories because I see them in our healthcare system today. But my worry is that could be amplified, it could be worsened. My hope, of course, is that it could actually be better, right? Every time that I worry about something being the bad side of things, I absolutely have the hope that if we do it right, we actually can provide better care, give people access to tools that get them diagnosed faster. So I see both sides of the coin, and I'm very hopeful. But I think anybody in this space that actually practices medicine also has a ton of anxiety that if we don't do it right, things could absolutely be worse too.
So now you are an ER doctor by day and a CIA agent, a secret agent by night. No, I'm just kidding. But who knows, right? If you're a secret agent, right? But what are they able to leverage your brain power with your AI excitement? I know the main skill you're doing is seeing patients, triaging, taking care of, but are you using that skill also, this fascination in all things AI and everything you're doing as well?
I mean, not every day in my clinical life, but I also don't think clinical medicine is totally there yet with kind of a lot of the predictive tools, right? Machine learning and neural networks to predict disease or diagnose disease faster. But yeah, certainly the other half of my healthcare job for the Permanente Medical Group, which is the medical group for Northern California for Kaiser Permanente, is that I work on AI and kind of clinical technology operations. I've been on our EHR steering committee for about 8 or 9 years now, and I'm now even focused even further on kind of innovation, pushing the organization forward, kind of advanced development. So yeah, I'm absolutely getting to use my like excitement in a new way, which I'm absolutely loving. In my clinical job, AI is not nearly as impactful, right? We are using AI scribes. We were probably the first large medical group to do so on at scale, which was really exciting. But as far as like reading a CAT scan, reading a chest X-ray, taking a patient's symptoms and figuring out what disease process they could have, that's still all in my brain and just using human. Right? There's a radiologist reading the CT scan, and I'm looking at it. I'm interpreting the labs myself. There's not AI tools in my EHR that are kind of hopefully helping me say, oh, hey, Graham, there's low platelets and renal failure. Does this patient have, TTP, which is this kind of rare, vascular disease thing. So still not there yet. And honestly, I think we're probably several years away from that still.
So you're an inventor too, right? You created your own. Tell us a little bit about. It's not just a calculator; it's an MD calculator, right?
That's right.
It's a medical calculator.
Yeah. So Michael, there are a bunch of published prediction scores and other types of kind of math that physicians need to do on a daily basis. They, one example, if you come to my emergency department and I diagnose you with pneumonia using some lab values and some vital signs and maybe your age or some risk factors, it can help me predict, should I send you home with some antibiotics, or really do I need to keep you in the hospital with your pneumonia? So they're really focused questions that a doctor might have. Does a patient have this disease or that one? And so we, back honestly almost 20 years ago now, I started kind of collecting these. I knew how to program HTML and JavaScript and kind of put them all on one site, called it MD Calc. And now we serve, we're several million uses every single week. And it's, primarily exclusively physicians and other practitioners, right? Nurse practitioners, PAs, medical students, residents, to get through their day of practicing medicine. And, then I guess I also view it as like, hopefully helping them to deliver better care, right? I tend to think that more evidence-based care is generally better care, that they're using a resource to help them decide, hey, does this patient need a CAT scan or not? How can I safely deliver care to them in a better way? So yeah, it's we're used probably by about 2/3 of American physicians every single month. We've got, I think we're about up to 800 calculators. It's entirely free. And it's funny, you get 1 degree of separation outside of like clinical practicing of medicine, and most people have never heard of the thing. Even if you're, even if you are, say a hospital administrator, you work with doctors every single day, you probably have never heard of MD Calc because it is so nichely focused on people that see patients every day and need to make kind of clinical decisions. But then, you like text any doctor and they're like, oh, I've had interns and residents like take selfies with me when they find out that I made MD Calc, because they're like, oh my God, I use this every day. Thank you. It's very flattering. I mean, I'm always
this is really coming from the way your mind works. I mean, you're a solver, you're a problem solver. You use coding, you use math, and basically you were solving something that you needed out of necessity.
that's what I've always done, and that's what I tell other people to do is, it annoyed me that, I mean, the nice way of saying it is that it's from my brain. That the real way of saying it is like, oh, it annoyed me that I didn't have access to all these tools already. And so I was like, well, I'm just going to build this for myself. And then it ended up being useful for other people too, right? I tend to find things that like kind of just get under my skin that are like, why isn't this, it's that feeling of this should be easier. I always tell people like, that's a great, when you feel the should, it's like a key spark for innovation, because something in your kind of subconscious brain feels like this should be easier, feels like there should be a better way to do things. And that usually should be a trigger to think like, well, hey, there's got to be a better way to do this. If you're intrinsically feeling that it doesn't need to be this painful to have 20 clicks to order a medicine or something, right? That's right. That means something right for innovation. And that's what I've always done is like, oh, this thing is annoying that it takes extra clicks, or that this thing can't talk to this thing. That's what I always do, is just find ways to make things easier for physicians primarily, because that's what I tend to be, the most focused on, the best at. But I've also done like little patient-facing tools too.
Do you see yourself ever starting an AI sort of physician geared solution technology company?
I've thought about it. I think it's going to be really interesting how AI progresses in medicine. I feel like these two competing theories of like AI is moving so fast. This. Every week or two, there's some new crazy thing that I'm like, oh my God, I have to tell everybody about this. I need to tell our CEO. I need to tell our whole C-suite about the new tech that's just came out in AI that's going to change AI again. And then the other side of me is like, wow, healthcare is slow to change. If you think of any other industry, it adopts change much faster than we do, from both a tech perspective and also just like a way that doctors deliver care perspective. The statistic that gets thrown around is like it takes 10 years for something that is like solid evidence in the literature to actually get adopted widely by medicine. And as a practicing physician now that's like kind of middle-aged, I get that. I understand why.
You look like you're about 23. So anyway, I'll stop there.
Yeah, thank you.
You're 24. You're just 24.
Filter on my phone I'm going, but I get why it is hard to change the way you practice, because you do things a certain way in residency. That way works, or that's a safe way to do things, and so it's hard to change. And so, getting back to your original question, I think it's going to be somewhere in the middle, where AI will force medicine to adopt much faster than we ever have before, because we'll be able to see that the data, we'll be able to get the results that prove to us that this thing is safe or good or not good, right? We'll be able to test systems much faster. The journals are having to publish this stuff much faster than they have as well, because they're kind of competing with each other to be like the leading place that people talk about and publish it about, kind of clinical AI. So, I'm thinking that's going to mean that it like things are getting adopted in like 3 to 5 years as opposed to 5 to 10, right? Like that's the scale that I think things will accelerate. But the thing my little catchphrase that I always say is doctors need things to be safe, fair, and accurate for us to adopt them. No doctor is going to adopt any technology that might hurt their patients because it's not safe, might be unfair or biased in some significant way against a race or a skin color, a sexual orientation, anything like that, right? Where no doctor would accept that. And then obviously it also needs to be accurate. No doctor would accept a tool that tells them one thing and then the other thing happens to be true most of the time. So those are the three pieces that doctors are going to require in order to adopt any clinical AI tool that either has a significant impact on patients or is patient facing either, right? I mean, if you have a chat bot that's telling patients, it's been programmed to tell patients how to manage their diabetes at home and it's wrong, well, no doctor's going to accept that either because that's totally out of the control
Which
of the
sometimes more often than not, like I've heard some of those RPM device companies, like 6% failure rate. Can you believe that? Talking about getting on a plane with that 6 sigma of nothing, man. Jeez.
Yeah, it's a challenge, right? And the other thing, Michael, that's kind of I think about from an ethical perspective a lot is what is the where do we draw the ethical line of having a tool that's really good when we have so many people in the United States that don't have health insurance at all, and people that have like not great health insurance, or people who just don't have great access to care because they live in a rural community or they live in a poorer community. Where is that line of like, hey, well, at least we could give patients a tool that's like 90% good, or 80% good when currently they have 0, versus, we don't want to give people a tool that's inaccurate.
I always have a crazy thought. Like there was a time where electricity was only for the wealthy. I mean, imagine if we had healthcare. Like, I mean, I say this every once in a while. I'll just say it to you. It's not possible at this point. But healthcare should be the cheapest service when you really think about it. I mean, I'm just saying, and I'll stop there and what your thoughts are, and then I'll stop.
I saw Sam Altman speak with Kara Swisher a couple of weeks ago here in San Francisco, and he had a very optimistic view of Gen AI and general AI intelligence, and he said. And I think LeCun, the Meta Facebook AI lead, has said something similar. Is wouldn't the world be better if everybody had access to like the world's best administrative assistant or the world's best manager? Or I think LeCun has said like, doesn't the world have to be better if there's better intelligence and better information for people? I hope so. I mean, there's a million ways that could go wrong, or bad forces could co-opt that or use, inherent human flaws for nefarious purposes. But generally, if you think of it that way, then everybody having access to an assistant that helps them perform at their highest level or helps them stay organized, whatever you struggle with, whether it's organization or staying on task or whatever it is. Imagine if you have like a coach or a guide that's helping you from that perspective. When you think about it that way, it's like, God, things have to be like, things could be amazingly better, which is why, he's apparently Altman's trying to raise like trillions of dollars.
And he probably will, I guess. But what do you think about metabolic health? Like when I hear and the little that I don't have any of these diseases yet where I can be necessarily treated, diabetes, but I'm pretty much there. Do you think we're going to get there with better? I'd like to think our reimbursement would be connected there, that we'd start treating earlier. I know there's some wacky, crazy science out there that isn't science too. We have to be careful, but it seems like our healthcare system is too sick care still. So I'll stop there. What's your thought on that?
I'd agree. I mean, I'd agree with you generally, Michael. I read Peter Attia's book, and that's where I think a lot of people have been exposed to these kind of concepts of, his 4 horsemen of the apocalypse, or of kind of human disease and frailty. And I generally agree with him. I think, we need to focus more on metabolic health, but I will also say, the healthcare system cannot counter, years and systems that fight against metabolic health, right? The healthcare system, I don't care how many drugs and GLP-1s and metformins and glipizide and insulin we have to fight against it. If we continue to have societal changes where we don't structure our cities and lives so that we are kind of encouraged or forced to move and be active, if we don't like find ways of improving our food supply and encourage people to eat less processed foods and make healthier choices. A lot of other countries have chosen to just make all of these things part of their citizens' lives. There's no healthcare can't do it, right? There's not going to be enough drugs to deal with the metabolic health badness and save us all from, hyperglycemia and the consequences of diabetes, which is like the worst disease you probably can get, that we have some control over. And so while I agree with Peter Attia, and I actually recommend everybody read his book, my criticisms of his book are that, this cannot be just a medical problem, like a healthcare problem. It has to be a societal change. And that for a lot of people, they, right now, they don't have many choices. They have a certain place they live, and their only job opportunities are a car drive away, or an hour car drive away, and their income only allows them to eat highly processed foods. And you're absolutely right. It will cost us in the long run. It is always crazy to me that we won't pay for somebody's insulin, but we will pay when they need to be hospitalized because their glucose is out of control. Or, if we won't pay for their insulin, but we'll pay for their foot amputation. All of that, all of those perverse incentives in the system have to change if we have any ability to kind of reverse course on a lot of the diseases he talks about in his book, and specifically metabolic health in particular.
I think I saw you write a little something on it on LinkedIn, and I tell you, those little things work, because I got encouraged to read it, and I almost finished it. I don't know. I was just distracted because I got it. I got the principles. I don't necessarily agree on all the different. I guess he thinks people should take certain medications, but I mean, the bottom line is it's the overarching concept, I think, is good. It'd be nice, and I am now going to a functional integral practice group, but they're trying to sell you all their things too. So it's like buyer beware everywhere. It's like, but I think what you brought up, we need to exercise more. We need to sit in chairs less. There's a lot of these things that are just designed like sitting is the new cigarettes, I guess. Yeah. So anyway.
Yeah. Sedentary lifestyle. I mean, I guess technically we should be standing and on a little treadmill to be talking right now, Michael.
Yeah, but we're here to talk more about AI and the future of technology with Dr. Graham Walker. So where do you want to go? We're still here. We still got plenty of time. I don't want to lose where we're supposed to go. This is a great opportunity. We got someone super on top of all things AI, all things efficiency. You love these efficiency things too.
Yeah. I think the next 5 or 10 years of medicine are extremely exciting to me, because we will start seeing a lot of clinical tools, right? That's I think what really tends to excite physicians, is clinical tools that allow us to come up with a better way of delivering care. So we will be able to we'll be able to predict strokes better, heart attacks better, know when a patient has something on an EKG that we think is a heart attack and it's not. And so we don't expose them to the risk of having to get, a catheterization to look at their blood vessels. Or the EKG might be super subtle. And so an AI tool could actually help us not miss a heart attack, which is also important. Right. So I think as physicians and nurses, pharmacists, anybody in healthcare sees all of the ways that the system still is way far from perfect. And I'm not even talking about kind of from a health equity or a lack of health insurance lens. Like, I'm talking about just that we currently lack the sophistication of our tools to kind of more perfectly align what the what disease the patient may have with our ability to either treat it or diagnose it, right? A lot of the ways that we, for a lot of conditions, we still do things like, well, such and such has these risk factors and this thing happened to them, so we should admit them to the hospital for 3 days because they might have something wrong with them. That's still how we do things. And, hospitals are not the best places for people who aren't sick and don't need a hospital. So I think the reason doctors, nurses, everybody is so excited about these AI tools is they can actually help us eliminate some of that friction that still exists today in modern medicine, where we still don't really know, does this person have this disease or not? Or should I really give this drug or that one, or not give this drug, or do this surgery or not do this surgery? There's still, I don't know, probably 5 or 10% of medicine where it's still not totally clear what the right thing to do is, which is why we tend, we're going to default to the safe course of action, of course, right? That's always going to be the right thing to do. But if we could save an old, say an old person who's high risk for getting delirium, which is very bad, if we could save that old person from needing to be in the hospital because we can say, okay, based on this EKG, you definitely don't have XYZ, heart attack, kidney failure, whatever it is, right? If we could save them that risk, that exposure to that risk, it would be better for everybody. I mean, I truly do think there are going to be a lot of areas where it's like win, 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 right? It's better for the patient. It's better for the healthcare team. It's actually cheaper for the health insurer. It's literally better for them. It's better for the hospital because the hospital is not kind of using that bed, which is a scarce resource. It truly has the potential to be better in every way, which never happens in healthcare or in systems.
Yeah, so I love what you're talking about. So I think where we're going here is the next 10 years, what are hospitals doing to plan for literally the obsolescence of 30% of their capacity or need? If we get it right, you're talking about really much better precision medicine, using diagnostic tools potentially outside of the hospital. I like that. I think it sounds good. That could be a win.
Yeah, Michael, it's interesting. If I was like an epidemiologist, or if any of your listeners are epidemiologists, I think the interesting challenge is, I think in the past decade, pre-COVID, but in the past, pre-COVID, in the past 5 or 10 years before that, there really was a sense that everything was going to move, or much more was going to move to the home quite rapidly, right? This hospital at home concept. And that we would need actually fewer hospital beds, right? And so I think there was a general sense in the kind of hospital building, healthcare system world that hey, maybe we shouldn't build a lot more hospitals because they're going to be empty, like you said, right? And you can't run a hospital with 5% capacity. But what we're seeing now, and I don't think it's really due to COVID anymore. We were blaming it on COVID for several years. It's just the aging of our population. I have never, I never in my career have I managed so many chronically ill patients. And I'm an ER doctor, right? I tend to manage mostly acute stuff, but so much of my day is filled with, somebody has a chronic condition and they're kind of, they're tilting the wrong way. And so my job is to tilt them back the right way. And sometimes that means admitting them to the hospital. Sometimes that means starting or stopping a medicine. But I was working a shift on Friday night, and I was just reflecting on how many additional tests I needed to do on these patients because they were older, they had other comorbidities, they were on drugs that made them higher risk for XYZ. I'll give you an example. I had a very elderly gentleman who'd taken a fall, but otherwise he was in very good health. He was on a blood thinner, but otherwise he was a very healthy guy. He had a little bit of kind of early cognitive decline, maybe early dementia. But, he was independent. He lived with his wife. They were a super adorable, sweet couple. But just because he was so elderly and he fell, fall from standing, just ground level fall, I had to do way more tests on him because he had such a higher risk of breaking something, having bleeding, having internal bleeding. So, he came in, he had a head injury, broke his nose. He also had a swollen calf. Usually a swollen calf in the setting of trauma in a very elderly patient means they broke their tibia, right? They broke but in fact, he ended up having a blood clot of the calf muscle. Not a super common thing. I mean, obviously it's well known enough that was in my list of things. But in order to diagnose all those things, he needed an X-ray, a CAT scan, and an ultrasound, as well as numerous other tests. And if he was 30 years younger, or even 20, honestly, even 20 years younger, he probably would have needed half of those tests.
Yeah.
So patients are just higher risk. They're more complex, and therefore they need way more testing. Again, for me to be able to say, hey, it's safe for you to go home. I don't think anything bad's going to happen if you go home. So that's the two opposing forces in that side. We have an elderly population who's living much longer with disease instead of dying from it, which is good, right? More years of life is a good thing. Healthy years especially. But when they get sick, they really get sick enough that they need to be hospitalized. There are more people that need to be hospitalized, but hopefully for shorter periods of time.
Yeah.
The amount of imaging required in particular is really challenging to our radiology colleagues. I mean, there were all these people 5 or 10 years ago saying, oh, we should stop training radiologists. AI is going to take all their jobs. Well, at least right now, we're needing to do more imaging tests on more people, which is building the queues of imaging studies to read by radiologists and causing a ton of stress for that specialty.
I'm glad you shared that perspective, because that's probably reality, and I guess that's probably more the truth across the country. And so you're probably seeing more building of hospitals. The hospitalists are like, yes, we're going to still be in business for 15 years with these, the aging population.
Yeah, and there are places that are thinking of kind of a new version of a hospital where it's like there's an ER, there's like a short stay area where people might stay for a day to kind of get them totally tanked up and tuned up and fixed up, and then they're kind of released, and maybe they have a longer period of time where they're at home with some home monitoring. And then there's like an ICU and an OR, right? So the critically ill people go up to the ICU. The people that need a surgery go to the OR, and then maybe go home the next day. And then people that just need a little bit more time spend like a night in the hospital, but then go home with a kind of a longer monitoring period at home, as opposed to the current setup of a hospital is like, well, it's mostly regular beds for people that aren't that sick. There are some ICU beds, there are some ORs, and there tends to be a kind of a larger ER, since ERs tend to send about 80 to 85% of their patients home after a workup or tests or treatments. So that may be another version of a hospital where people get a big workup in the ER. The ER kind of manages them. Maybe the ER gets them hooked up and coordinated with some monitoring at home, or they have a brief stay in the hospital. But the days of like spending 3 days, 7 days, 2 weeks in the hospital are you're either critically ill enough that you truly need that, or hey, can we get you home safely? Send a nurse into your home 3 times a day to check on you every day. And the data is I think pretty clear that you're less likely to have falls, less delirium if you're sleeping in your own bed, eating your own food, than in a very hyper controlled environment like a hospital.
So let's get on to the practice of medicine. Like, how can we make doctors better? I think this is where I want to focus these next, let's say 10 minutes. Let's dive deep onto this, because I look at you as like kind of like a healthcare doctor ninja, let's just say, like a I don't know. I mean, I just see the way your mind's going and how you're working through things, that you could have the little studio to make doctors get the things right, if you could imagine that. So let's just imagine that you could create the perfect setup to make the perfect thing go for a doctor. What would that look like?
Man, that's a good question. It's probably different things to different specialties. I'll be honest. I don't, I don't really know what a pathologist does all day. I have an idea from med school 20 years ago, but I don't totally know. I don't exactly know I have an idea of what the challenges are of a surgeon or a pediatrician, but I don't exactly know. I did a fellowship in simulation medicine at Stanford. And the idea there, it's very hot. Sim is kind of very hot in specialties where you need to act fast. So that's like the ER, anesthesia, OB, some surgical specialties. And the idea there is there are some conditions that you may see once or twice in your career, like you're working for 30 years, you might see this disease once or twice, that, if you don't recognize or you don't do correctly or you miss, the patient will die or they'll have a much worse outcome. And so part of sim training is training physicians for rare events that they need to know how to handle. Part of that is a refresher course on just the education, right? Like there's a condition called thyroid storm. It's when your thyroid levels are extremely high and it can be fatal. And you might see that once or twice in your career. And just having a refresher from your days from residency that might have been 20 or 25 years ago. Hey, what is this thyroid storm? How does it present? What are the starting points of treatment? So there's an education refresher component. And then the other component of simulation is really, it's soft skills. It's communication. It's knowing how to ask for help. It's knowing how to delegate and relegate responsibilities and assign tasks to people. It's knowing how to rally resources and call for help and assistance. So it's a mixture of those two pieces. I would say that is that's a key piece for like emergent physicians like myself, but maybe it's probably not a super critical thing for maybe a pediatrician or a primary care doctor. So I would probably say, building a better doctor probably involves knowing what each specialty, finding somebody like me for each specialty who can really say, here are the challenges that happen for, a doctor that's 10 years out of practice in internal medicine or nephrology or cardiology, whatever it is. And then, Michael, I'm of course going to add in a tech component. I mean, I would love to I'd love to have a trusted AI consultant sidekick, right? I am maybe nearing the end of my career in 20 years, I will be ready to have AI on autopilot for, much of the case or for many of the patients. But, right now I would love to have a trusted AI sidekick that I can just like what we call curbside, right? Meaning, I'll be working a shift in the ER and I have a colleague with me and I say, I just can't figure out this case, or I want to make sure I'm not missing something. So I'll just pull them aside and say, hey, can I ask you a couple questions? I have this guy, he's 56 and he is saying that he's having some blood in his poop, but his blood count is normal and his blood pressure is high, not low. What should I do a CAT scan on him? So you generally just kind of talk through your thinking with another human, another doctor that you trust, and you try to see like you just bounce that case off them. Now, it's understood that a curbside means that other doctor has no medical legal responsibility, right? I'm not putting in their chart, discuss case with Dr. Mann and he agrees with my plan, But I would love to have that version in AI because the AI has been trained or has the knowledge of.
I hear a startup. I hear something. I mean,
wow. 100,000 of the world's smartest doctors, right? And they're trained not just on the textbooks, but they're trained on the papers and trained on the experience of trained clinicians as well. So that's what I think would make me a better doctor as well, is someone that when I actively know when I'm like, I'm just not sure, the AI tool could help me. And the other piece is like a little bit of don't want to, I mean, somebody monitoring me might sound a little big brothery to some people, but I'm not perfect. No doctor is perfect. We are humans. We are totally flawed creatures. We have nights where we don't sleep very well, and we're not as clear of thought as we are on other days. I would love to have some tool that is like saying, I'm about to write the discharge home order, and the things like, hey, Graham, you might not want to do that because, or, hey, did you consider that they might have whatever, thyroid storm, they might have an aortic dissection, they might have this. Yeah. And often that's all it takes actually for a physician to be able to like snap out of it. We think in type 1 and type 2 thinking. One is fast and one is slow. But I don't think any good physician would mind a kind of AI, monitoring is not the right word, but like an AI kind of
companion
tool that's like helping me to not make mistakes. Like
you're a AI amigo or amiga or whatever you want to say it.
Yeah, like, oh, hey, Graham, you're about to give a medicine that causes kidney problems to somebody that already has kidney problems. Like that happens all of the time, Michael. And right now we have warning systems in our EHR, but they're very rote, right? It's if-then statements of like, if the patient has kidney problems, do not allow this medicine to be prescribed, or warn the doctor, or it's all or the dosage is too high, or the patient has an allergy to this medicine. But or we'll even have some alerts that say, hey, the patient's labs are not back yet. Did you mean to discharge them? Because that happens too. Sometimes you accidentally write the wrong order or something like that.
So we're talking almost like a R2D2 or CP3. Doctor friend.
Hey, Han Solo, you're about to crash. You're about to drive into that asteroid. Did you mean to do that? Oh gosh, no, thank you so much. Let's correct course. Like that type of thing. And no physician is going to be challenged by that or annoyed by that if it's dialed at the right level, right? If it's firing on every single order, well, yeah, of course everybody's going to hate that because it's disruptive and not helpful. So it has to be fine tuned to that right balance of it's helping me when I need it, but it's not alerting me every time I try to do anything, because that obviously
is there any company right now yet doing any sort of sandbox play with that? I know there's a lot of ambient talk with all the different charts and stuff, but are they? I mean, that to me would seem like, my gosh, like every doctor wanting it, like your calculator. It would be like, are you going to do this now? Is this your next project?
I think it's a big challenge because of the complexity of medicine, but do I think it will get done? Absolutely. Am I the guy to do it? I don't know. Maybe I haven't started on it. But I do think it will happen. It may be stepwise too. It may be that it starts in it starts in orthopedics, or it starts in pediatrics. And so it's a smaller chunk of knowledge that the AI tool needs to understand or process. But eventually that's absolutely what I think every physician would want, is a tool that just helps them be a better doctor. Because I don't see us handing over the reins to AI anytime soon.
Yeah, I love how you said this. I love how this came up, and this has not been scripted. This is just through a discussion we've come to this. This is I think the beauty of why podcasting as a category is so awesome. These aren't scripted questions. I'm glad.
Michael and I just met 45 minutes ago. Yeah,
I'm glad you came on. I'm really glad you can make it today.
Yeah, this has been great.
Is there anything else that you'd like to just throw out in the universe while you're here?
Gosh, no, I think it's been really enjoyable to get to know a community of people like yourself that's interested in this healthcare space and how we can do it right and do it better. We launched this thing called the Physicians Charter for Responsible AI. It was a white paper that we put out, and it was really just like, me and a bunch of people, a bunch of physician friends I met on LinkedIn, and we were all kind of really concerned to make sure that this stuff was done safely and fairly and responsibly, because we saw how incredible ChatGPT was. I mean, truly, for me, this was like, I really was not aware at all of AI until ChatGPT kind of woke me up and was like, oh my God, what the hell is this thing?
Mhm.
And I think we were all concerned that AI was going to take over immediately, and obviously it hasn't in medicine. But we plan to update this charter yearly and just like look at what's happened in the past year of AI and see, hey, is medicine going in a direction? Should we address? Should we add a chapter? Should we remove a chapter? So no, it's something I'm also really proud of. And it was my MDCalc co-founder and I, and plus a mentor and friend of mine, Scott Campbell, that came up with this idea of like, hey, we should put together a white paper that's just talking about how we can make sure that medicine is still focused around the patient and the physician-patient relationship, and making sure that doesn't get lost. And if AI is part of it, it's a co-pilot, it's a helper, it's an R2D2, it's not a robotic Han Solo that's actually replacing the real deal, or replacing Chewbacca or anything like that.
Are you able to? Is that white paper available? Is it?
Yeah, it's just it's at physicianscharter.ai, and I made like a little interactive website that that kind of goes through the values and the values that frame it, and the all kind of 10 rules of the road. And then at the very top you can just click download, and it's a PDF you can download.
So if you could, I'd love for you to share with me, just email me, make sure I have that. And then
sure,
after
yeah.
this, I will make this available when I upload the newsletter. I'll have a little link for it. I think that's a nice thing available for others.
Oh, thanks, Michael. Yeah, I appreciate it. And and I guess the other thing that was just cool is we did this all asynchronously. It was all 10 authors. We just created a Google Doc and shared it and worked on it together. And then I went on Fiverr and found some people to help with the graphic design and the color scheme and the web layout, and made it interactive. So it's also just a testament to how cool the web is and the ability to do creative work, honestly, for relatively low cost, and put together like a really professional white paper with no, this was just us that did this, and being passionate and caring about the thing. We don't have like a big organization and a big nonprofit running the thing. It's just like, oh, let's do this, which you certainly couldn't do, 10 or 20 years ago. Just
I love that. I love the whole thing about passion, getting together with a community and centered around on a specific thing that you're doing.
Yeah.
That's awesome. Well, man, we're going to land the spaceship. We're kind of coming to the end. Any last things, Dr. Graham Walker?
No, I'm just excited for, I'm always excited for what's coming in AI, and no, it's always my interest to make sure that we, what we do is responsible and fair, and helps the patient, and is focused on making life better for everybody. And I truly think that AI can do this, of all the technologies I've seen. So I'm really hopeful and excited.
Awesome. Well, this has been great to have you on, Dr. Walker.
Thanks, Michael.
Planetary Health First, Mars Next, and we really covered some good ground. I hope you enjoyed us this time today, and you have a great day. And until next time, friends.